So our next presenter is Clay Jones, who is presenting on From Stigma to Hope to Healing, a shift in perspective on prenatal substance exposure.
Good morning. My name is Clay Jones with Maricopa County Department of Public Health, and I'm here to talk a little bit about a new collaborative called Maricopa Shift, which is Safe, Healthy Infants and Families Thrive. We do have a website for this, maricopashift.com. Encourage you to check that out at your convenience. Maricopa Shift is funded by the CDC in response to the opioid epidemic. We may lose sight of the fact that every single day in this country, we lose about 200 to 300 lives lost to overdose. Most of them involve prescription or illicit opioids, and it's over 100,000 lives lost in the last 12 months. For in the short time of this presentation, an average of 4 people in the country will have lost their lives from an overdose. So Maricopa Shift is a collaborative for expectant parents that are struggling with substance use during pregnancy, probably one of the most highly stigmatized population that we will encounter. These moms-to-be are afraid to seek any kind of help, such as prenatal care, substance use treatment, because of fears of losing their child and so on. A common outcome for babies exposed to opioids, such as fentanyl, or it could be other opioids in utero, is a syndrome called neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, and a common outcome for these babies that require specialized care. NAS is a subset of substance-exposed newborn, or SEN, a term you may be more familiar with. So how many of these NAS babies do we have? These are measured in terms of NAS babies per every 1,000 births. And you can see in 2009, we had about 1.5 NAS babies per 1,000. Today, we're over 11 per 1,000 births. And that translates to about 1,000 babies per year born in Arizona with this diagnosis requiring the specialized care. Since half of the people live in Maricopa County, we're anticipating about 500 of those born right here. These births are very expensive under the current way we treat them, and most of them are covered by Access, our state Medicaid. And you can see the difference in costs, about $50,000 or more per baby for an NAS baby versus about $3,000 or $4,000 for a non-NAS typical baby. So Shift is an initiative, a collaborative for all different types of providers that touch the lives of this population toward collaboratively, non-stigmatizing care and specialized care for better outcomes. We did not invent this. This was actually created about 15 years ago back in Vermont, and their initiative is called CHARM, Children and Recovering Mothers. The Vermont CHARM model is the only initiative of this kind endorsed by SAMHSA. So they're about 12, 15 years ahead of us now, and they see remarkable outcomes. For example, most of their newborns do not require medication for their NAS symptoms, which is typically morphine for the baby. They've seen an increase in the average birth weight. Most importantly, they see more and more of these babies going home safely with mom, with their families, rather than into care. Lower cost per delivery, lower cost to systems. It's just a win-win-win every way we look at it. The key to this whole work is prenatal engagement. We want to engage these moms in the pregnancy before that baby is born. There are a variety of myths surrounding expectant parents and opioids particularly. For example, if a woman is receiving medication-assisted treatment, such as methadone, becomes pregnant, a myth is that she needs to discontinue the MAT immediately. Again, we refer her to her doctor, to ACOG, to all leading medical authorities. By doing so would endanger the life of the mother and the baby. The NAS the baby may have or is likely to have is an expected and treatable condition. Another common myth is that if that baby is born, they do a drug test, they discover opioids, surely it must mean that she was using heroin or fentanyl during the pregnancy. While that is a possibility, there are several other reasons why the baby might have NAS. Could be because of prescription medications, such as Vicodin for chronic pain or other conditions. Could be misusing their own prescribed opioids. Could be from receiving that MAT I just mentioned about, or combination of several of these things. So we need to take a closer look. Another common myth is that, she's on MAT, she cannot breastfeed the baby. Again, according to ACOG and all leading medical authorities, breastfeeding poses additional benefits to mom and the baby. So we want to encourage that. There are a variety of best practices we are promoting with all of our collaborators throughout the county. And one of them is universal screening. There's a particular screening tool we have invested in and are supporting providers to utilize called the 4Ps Plus screen. It's the only validated screening tool for expectant parents, and it screens for substance use, depression, and domestic violence. Another best practice we're promoting is a little bit of education about infant mental health 101. Infant mental health is a field that places an emphasis on understanding the healthy social emotional development of the baby, birth to 3, the attachment and bonding between parent and child, and has many, many years of evidence-based tools and research behind it. Understanding these relationships and the importance of keeping mom and baby together. So what happens to these 1,000 babies we're looking at diagnosed with NAS? Well, the current approach, probably more than 90% of the babies experience here, the baby is assessed for symptoms, all right, the withdrawal symptoms that the child is having. And if they have a high enough score, they remove the baby from mom, the baby is placed in the NICU and is usually put on a schedule of opioids, a schedule of morphine, which is an opioid, to manage the child's symptoms. These hospital stays average 3 weeks or longer. These are those $50,000 babies we're talking about. This is the typical approach that we handle most of these births. Here's a couple of images of what a NICU might look like, or a level 2 nursery similar. These are not particularly parent-friendly places. They tend to be loud, noisy, disruptive, exactly the opposite of what these babies need. These babies need comforting. They need a quiet, dark environment to manage their withdrawals. So another part of the alternative that we're promoting is called Eat, Sleep, Console. Instead of the NICU, babies are placed in a specialized nursery where mother and father can stay with them. And the parent is the first person we go to console the baby. Parents can stay with the baby up to 24 hours. Overnight, non-pharmacologic measures are used first, and breastfeeding is encouraged. So these babies, we're seeing a dramatic decrease in the necessity of morphine for these babies, from about 90% of them in the NICU to maybe 5% of them using this alternative. This is what an Eat, Sleep, Console room might look like, very different than the NICU. Dimming the lights, along with the supportive medical staff to support the parent, and the parent is the primary caregiver. Really, the overarching philosophy of SHIFT, this is most important, is compassionate, non-stigmatizing care. What if these moms, or every professional they cross paths with, supported them in a non-stigmatizing, supportive manner? We talk a lot about this during our training and education around this. So once a parent does get involved with us, we're interested to find out what services she's involved in right now and what her needs might be. Our special focus is on prenatal care for the baby's care and substance use treatment for mom. And then because there's a variety of different types of providers doing different types of work, we look at filling in the gaps with our providers. I mentioned earlier the prenatal care is key to this. So once a report is made for a substance exposed baby or an NAS baby, report is made to the hotline to DCS and they have to investigate. DCS by federal law is required to complete this document called the Infant Care Plan that spells out safe sleep, safe responsible adults, pediatric care, and safety for the baby going home. We received authorization about a year ago to put the Maricopa SHIFT logo on the DCS Infant Care Plan. And we are actually working towards completing these before the baby's born, including a game plan for that baby to go home safely with family. This is a huge game changer for our systems. So over the last few years, we've recruited more than 50 collaborative partners. You'll recognize many familiar names, maybe a place that you work now. And we don't have room on here for all the 50 slides. This is just a handful of them. And those partners are comprised of over 100 stakeholders from these organizations and others. And one of the big parts of our focus is going around and providing this training on Zoom, or more lately in person, which is really, really interesting and engaging, and educating professionals about their role in this work and the importance of collaboration for non-stigmatizing care. If you've not heard of this program or not received this training, we encourage you to contact us. We'd love to schedule a time. Our training is about an hour and a half. We'd love to come and meet you at your site, at your office, anywhere in Maricopa County, and get you on board with the Maricopa SHIFT Task Force, as we call it. Again, you can check out the website, maricopashift.com. Our email and phone is at the top there also. I'm Clay Jones. I'm the coordinator with Maricopa County Department of Public Health, and we look forward to hearing from you. And thank you for your hard work and your time.